Yes, sir. I would like to call Dr. Urvija talking about the role of the topography and eye trace in the cataract surgery. Over to you.
This is all friends to improve the quality of post-operative quality of the vision. So we are covering the topics so that with add-on feature you can give a very good post-operative quality.
That's it.
Next one.
Agrawal.
Thank you, sir, for giving this opportunity. I would like to discuss something upon aberrometry and topography and its role in cataract surgery. We know cataract surgery nowadays, it's a refractive surgery and patient needs a premium vision at all ranges. We have extended range of technologies, good IOL calculator systems, IOL Master 700, Lenstar as sir was talking about, high-end phaco machines, premium IOLs. But even with all of this, sometimes we face refractive surprises in a lot of cases. And to answer this comes the help of eye trace, which is aberrometer with a corneal topographer. It is a 5-in-1 system which gives us ray tracing aberrometry, the whole eye wavefront, a corneal topography, autorefraction, autokeratometry, and also pupillometry. So this, the main function of it is it gives a whole eye wavefront along with corneal topography. The whole eye wavefront will measure total aberrations of the eye, and corneal topography part will measure the corneal aberrations part. When we subtract this total aberrations, and from this, when we subtract the corneal part, we get the internal aberrations, which mainly consists of the lenticular part. And this is how we can evaluate the results of our premium lenses, and also it helps in planning of what kind of lens you want to plan, toric, multifocal, or a aspheric lens. Eye trace also gives us a dysfunctional lens index. That means it assesses the condition of the lens in preclinical cataract cases also. So this was a post-LASIK case. Few years down the line after LASIK, he complained of symptoms of glare. On checking topography first, it was stable. On doing the slit lamp examination, lens was clear, but patient was accepting minus was fair with -1 cylinder. So on doing an eye trace, we observed that he had a high internal aberrations and a low dysfunctional index, lens index, which was coming down to 2.6. 10 is a very good lens functional disindex, and coming down reduces the lens quality. So here the lens quality reduced from 10 to 2.6, and internal aberrations were very high, whereas the corneal aberrations were completely normal. So this will suggest it is a preclinical cataract and not a lens regression, not a corneal regression after a LASIK surgery, and you need to plan a cataract surgery early for this patient. Then it also gives us information about angle kappa, angle alpha in cases of multifocal, because if you decentered, if angle kappa is very high, angle alpha is very high, so the lens, the center of the lens and the center of the visual axis are way apart, and this can cause complaints of lens, glare and halos to the patient. This is one simple case with an eye trace where you can measure an angle alpha, you can measure corneal aberrations, and if any of those, if corneal aberrations are high or angle alpha is more than 0.5, you must avoid a multifocal lens. Eye trace also gives us a very good simulation vision of a patient. This is a simulated picture of how the patient is perceiving a letter E at a high, at a mesopic pupil, and at a 2 mm pupil. It gives a range of simulated vision at all sizes of the pupil, and you can assess if patient is complaining of double vision, glare and halo, and it basically demonstrates an actual vision problem to the patient as well as to the doctor where the patient lies. I would like to discuss two cases, very interesting cases. This was a 40-year male, underwent both eye cataract surgery with a monofocal lens, and best corrected vision was 6.6. He complained severe dysphotopsia after 3 months of the surgery. So when we did an eye trace for him, earlier he was given all the lubrications and lubricants, but he was not satisfied. The eye trace gave this simulated vision picture, which was very blurred, internal as well as the corneal. The dysfunctional index had come down in case where there was a clear lens, clear IOL. Even then it was giving a dysfunctionalness index of 2.6. DLI was very low and high internal aberrations. And if you see, the aberrations increased from 1, this is 1 mm pupil size, it increased at 2, and it increased very much at 4 mm. So he was complaining glare and more at night. Eye trace also gives you a toric alignment check. So here the corneal astigmatism was just 1 and IOL astigmatism was given as 1.5, whereas this was a simple plain monofocal. There was no toric implanted. So why was this giving a toric alignment here at 1.5 diopter? So when we checked on the slit lamp again, we realized that that toric correction is coming due to the capsular bag fibrosis. And all these findings just help you be more confident about how you want to plan this. Capsular fibrosis was assessed on eye trace. So when we dialed the bag, the fibrosis was released, and you can see the post-op eye trace improved, the simulated vision and the post-op simulated vision. It improved significantly the internal abrasions. This is pre-op and this is post-op. Internal abrasions reduced drastically and patient was happy. This is second case of post-RK. Right eye cataract surgery was planned. IOL master failed to capture any keratometry in this. So keratometry was captured on a topographer. So we planned topography on a Scheimpflug based and also on a Placido based topographer. So this is a pentacam picture. This is a very widely used topographer nowadays. So we did a pentacam topography. Pentacam gave 11 diopters of astigmatism at 164 axis. There is a very good EKR report. It's a equivalent keratometry reading given by the pentacam. It takes care of the anterior as well as the posterior corneal astigmatism, and it gives you an equivalent reading what you should plan. Ideally, a 4 to 4.5 mm size of the pupil is what is usually planned. It gives you a good reading. So the EKR map gave a astigmatism of 6.23, whereas the normal refractive map was giving 11 diopters. It was way different. So it reports the keratometry value just adjust for the back and surface power deviation from the average. This is the ASOCT based topography for the same RK patient. Here the astigmatism was coming minus 7.8 and the posterior corneal was coming plus 1.7. So if you subtract 7 with plus, it comes around to be same as minus 6 cylinder. So it matched with the holiday EKR report on the pentagam. So we planned a 6 diopters of cylinder with plus 19.5 sphere, and residual refraction came out just 0.75 on patient, and we got a very happy patient. So thank you very much. I would just conclude that aberrometry and topography can help with patient education, preoperative counseling, better outcomes and satisfaction of the patients, and postoperative assessment as well. Thank you.
Yeah, thank you, Dr. Urvija, for that wonderful